Well, good afternoon, everybody. I've been asked to introduce our speakers here today. We'll have three people speaking. First will be Dr. Rao, who is a clinical assistant professor in the Department of Pathology and Anatomical Sciences. She is the director of Gastrointestinal, Pancreaticobiliary, and Hepatic Pathology. And she's basically an expert in the field of GI pathology. Dr. Rao did her training at Memorial Sloan Kettering in Weill Cornell Medical Center for gastric and hepatic pathology. And she also has a Master's of Science in Bioinformatics from the University of Missouri. Needless to say, all our speakers today have numerous publications and are actively involved in research and obtaining competitive grants. Our second speaker is Dr. Katsiaryna Laziuk, who's an associate professor, again, in the Department of Pathology. Dr. Laziuk is an expert in hematopathology and hematology, as well as surgical pathology, having done fellowships in hematopathology and surgical pathology, both at Albany Medical Center and the University of Texas. She spends probably half of her time on hematopathology and about a quarter of her time in surgical pathology. Our last speaker is Meredith James, who is the Chief Commercial Officer at Flagship Biosciences, which is a leader in data-centric pathology services and tissue analysis. The mission of Flagship is to improve drug development and diagnostics using the power of artificial intelligence, bringing new insights to tissue analysis from its CLIA and CAP certified laboratories. Meredith has been with Flagship since July of 2019 and has led translational programs for precision medicine. She has a BS degree in biology from Virginia Polytechnic Institute and State University, with a Master's of Science and MBA in biotechnology from Johns Hopkins. Notably, Meredith this year was named one of the top 25 women leaders in biotechnology. Those are our speakers today, and we'll go ahead and get started with Dr. Rao doing the first part of this conference.
Okay, I'm sharing my screen. Unfortunately, my camera is not working today, so hopefully that should be okay. Do you see my screen now?
Yes, it looks great.
All right, okay, I'll get started. I'm Deepthi Rao, and as Dr. Hammer said, I'm a GI pathologist. I'm going to give you a brief overview on the immunohistochemistry. So now the roadmap of my talk is as follows. I'll initially give a bit of brief introduction and steps of the IHC, then common applications, markers of differentiation, and why the location matters in immunohistochemistry. Okay. So now to give a bit of a brief introduction, immunohistochemistry is a hybrid branch. So it started chemistry, which is a branch of science that combines the techniques of biochemistry and histology in the study of cells and tissues. The second branch is the immunology, and as we know, it's a branch of science that deals with the immune system, cell-mediated or humoral aspects of the immunity. The combined field is the immunohistochemistry. It started as a field, but it is it's part of our daily lives. So we study immunohistochemical stains as part of our routine work. So immunohistochemistry now, as a hybrid branch, it studies the localization of known antigen in the tissue, and it utilizes that by using the antibodies that are directed against those specific antigens. So now there are a lot of steps involved in immunohistochemistry. It starts with the fixation, and then there are about 15 different steps. And finally, we get to the microscope, and that's where we visualize the tissue at the light microscopy level. And to shorten those steps, There is another picture here, an infographic that has reduced it to about 10 steps. In any way, it's like tissue sections are taken and then the antibodies, primary and secondary antibodies are used, and then the counter stain, and it's mounted, and we get the slides for microscopy observation. So the common applications are numerous, but I'll go over about 5 applications. Number 1 application is diagnosis of tumors. The second application being immunohistochemistry is used as prognostic markers for many. And I'll go over a bit of detail in the following slides. The third application is its usage as predictive or theranostic marker. The fourth application is detection of micrometastasis. And the other application, it's not about tumors always. We use them for identification of infectious organisms as well. So now looking at the first application, which is the diagnosis of tumor, that's probably the most common example or the application that we use for on our daily workload. So a few examples are as follows. The first way in which we use it with tumors is to classify a poorly differentiated neoplasm when the lineage is hard to tell just based on the microscopic features. For example, if it's carcinoma, it's usually cytokeratin positive. A lymphoma, CD45 is the basic stain that we would do, and further classification would be done, and Dr. Laziuk is going to cover more on that. Melanoma, we would do one of the melanoma markers. So that is the first way. Once we know what the lineage is, we would need to know what primary it would be. To just give you a few examples, gastrointestinal tract primary would be CDX2 positive. It's lower GI, SAT-B2 positive, lung, TTF and napsin, prostate NKX 3.1 and PSA, and so on and so forth. The other way it can be used is for the diagnosis of invasion. Here, the loss of staining is of importance. In the other two, the presence of staining is important. Here, we look for the loss of staining. If there is loss of staining in the myoepithelial cells, as in breast cancer, we could diagnose the invasion. In a similar way, the loss of basal cells in prostate cancer, and so on and so forth. The next application, as I mentioned, is the prognostic markers. This is quite common in our workload. Ki67 is a general proliferation marker. It's especially useful for me in neuroendocrine tumors and other cancers where we need to see how fast it's proliferating. The other marker I use on a daily basis is mismatch repair markers. It's done on all gastrointestinal tract tumors as well as endometrial cancers. Another marker is HER2. It shows the adverse prognosis in breast and gastric cancer. A CD38 is another marker for CLL. The next application is as predictive markers or theranostic markers. Here, ER/PR and HER2 are used in breast cancer. HER2 alone is used in gastric cancer. PD-L1, as we know, is used in several cancers, especially lung. c-KIT for gastrointestinal stromal tumors, and CML, ALK for lung cancers and other cancers. So the next, before we talk about the next application, I just want to show you how we would select the tissue. Just to give you an example, let's say this is a tumor tissue on this side and a bit of normal. And this is subjected to mismatch repair immunohistochemistry. So we usually select the sample that has a bit of normal as well, because that can act as our internal control. And we would like to select the section in a way that's very well fixed and it's not too big and not too small. And so the selection of the tissue also matters. Sometimes we use the immunomarkers in pairs, as in mismatch repair, where MLH1 and PMS2 go together and MSH2 and MSH6 go together. So it's not always one marker at a time. Sometimes we do like a panel and observe them. Two more application. Detection of micrometastasis. This is especially helpful in melanoma using melanocytic markers and breast cancers using cytokeratins. The last application that I'm going to cover is the identification of infectious organisms like viruses. It could be CMV or herpes simplex virus, adenovirus, bacteria, H. pylori, and other things. Immunohistochemistry is extremely helpful both in tumor and non-tumor cases. So now coming to the markers of differentiation, there are several lineages, several markers of differentiation. In fact, our lab does more than 100. And if someone is interested in studying any of these, or even the newer ones, we could validate them and help you with the studies. Although my area of interest is gastrointestinal pathology, as you know, a majority of the tumors metastasize to liver. So dealing with different tumors and different markers is part of my work life. So I'm quite comfortable with most of the markers. And if anyone is interested in any of the immunomarkers for your studies, our department can be helpful. So now looking at the markers of differentiation, epithelial markers, cytokeratins and EMA. The next one is the melanocytic. Several markers are there. We usually use S100, SOX10, and one of these markers. Neuroendocrine, we do have synaptophysin, chromogranin, and CD56. So one of these markers, and sometimes we do in pairs. The next differentiation is endothelial. Here, an interesting thing is if we need to see if it's in particular lymphatic versus venous, we can even use D240. Smooth muscle markers, Desmin, SMA, MS actin, and so on and so forth. Skeletal muscle specific are myogenin and MyoD. Some more markers of differentiation, serous acinar cells, trypsin, chymotrypsin, BCL10, and PAS. For GIST, we use CD117 and DOG1, and histiocytic lineage, CD68 and CD163, glial, Schwannian. Another important thing is we also look for the distribution. For example, MS actin or smooth muscle actin, we saw that these could be used for smooth muscle differentiation. But if it's for myofibroblastic differentiation, we look for a tram track distribution. So as pathologists, we have a lot of expertise in looking at the pattern, the staining distribution, and so on and so forth. Myoepithelial markers can be polyphenotypic like SMA and P63. These are just a few examples. There can be many other lineages. So now the location matters in immunohistochemical staining and studies. Here is an example of Ki67. As you can see, it's a nuclear marker. So these are the nuclei, and the nucleus is taken up strong dark staining. So this is nuclear. And to contrast that, I have a cytoplasmic staining of cytokeratin, and except the nucleus, everything else is staining here. So the nucleus is spared. So a location can be a key. Here is my third example, which is the beta-catenin, in that both the cytoplasm and the nucleus have taken the stain. In fact, here I'm showing you that only the cytoplasm is positive. Here, both the cytoplasm and the nucleus are positive. The nucleus being positive is the key. So we would call it positive only if the nucleus has taken the stain. The fourth example is HER2, where it's the membranous stain. The cell membrane is taking it up. So now to sum it up, let's say this is the cell. And here's the nucleus, the cytoplasm, the cell membrane. So the first pattern is the cytoplasmic reactivity. It could be diffuse like the one that I showed, the cytokeratin. It could be granular as in heparin or napsin. Dot-like positivity in case of cytokeratin and Merkel cell carcinoma. So the reactivity and also the pattern matters. So now I'm trying to match the colors of these. So if you look at the nucleus, if there is nuclear reactivity, it could be the proliferation marker of the Ki67 that I showed, or ERPR and other markers here. The third type of location that we look for is the nucleus plus cytoplasmic reactivity. As I showed, one of them was the beta-catenin. And the fourth one is the membrane, and it could be CD3, CD20, or HER2, as I showed in the example. So it's an exciting field and exciting array of stains, which can be extremely helpful on a day-to-day basis for diagnosis as well as research. And with our expertise in these stains, we can be quite helpful for any of the studies that you would be looking for in the future. Happy to take questions. Thank you again for the opportunity to present. My contact information is also listed in this slide. Feel free to contact me in the future. Thank you.
Okay, so as Dr. Rao mentioned about immunohistochemistry, it's a well-established and widely accepted method, and we use it in both as a clinical service or also as experimental medical science. And the method is for localizing specific antigen in a tissue or cells. And the most important critical component of any IHC, it's the antibodies that we use, and it's a target of cells. So we need to know what we are looking for and what we are marking with those antibodies. Because if we just marking everything, it would be very hard to later on interpret the staining and know what is this immunostain is marking. Okay, so IHC takes a long history, more than 70 years. In early 90s, it was found a general application in surgical pathologies, and in nowadays we use it as a routine. We use it every day on day-to-day basis as a surgical pathology, hematopathology, and also as a research application. When we use antibody, it's important to know sensitivity of antibodies and specificity. Because if you saw, as Dr. Rao mentioned, we can apply different antibodies, and sometimes the same antibodies may mark different tissue. And IHC, when we use it, is adjunctive method. It's a method of help. It's an aid method. We usually use a diagnosis based on morphology, and then use immunophenotype as a helpful information, as a prognostic value, or sometimes also as a potential target for the therapy. Panels that we use should include positive expected and negative expected. Always use positive controls and negative controls, and no pattern of staining, nuclear staining, cytoplasmic staining, or membranous staining, and again, apply the results of IHC in a specific morphology and clinical context. So when we're talking about panels that we use in hematopathology, so as we know, the CD45 immunostain stains the hematolymphoid cells. And from hematolymphoid cells, we have B cells and T cells. When we're looking for B cells, so for B cell antigen, we usually use several markers. The first line is a CD20. But for CD20, there is a monoclonal antibody directed against CD20, which clinicians use for treatment as a rituximab. And when the chemotherapeutic regimen contained rituximab, in the future biopsies, CD20 would be negative. That's why we usually use the whole panel of B cell markers, including CD19, CD22, PAX5, and 79A. But why we use it? Because sometimes CD19 also will be positive in normal plasma cells, and 79 also will be positive in plasma cells. So we need to know exactly what we are looking for. And in case of B cells, we use CD20, PAX5, CD19, and CD79. So another marker that we use in hematopathology, and we are looking for example, for hairy cell leukemia, annexin A1 is a very specific marker for hairy cell leukemia. For CLL, it's a LAF1. For mantle cell lymphoma, cyclin D1 and SAX11, but cyclin D1 also can be positive in 15% of plasma cell myeloma, multiple myeloma cases. That's why we use cyclin D1 together with SAX11, plus sometimes it may be SAX11 positive mantle cell lymphoma. For marginal zone lymphoma, we use MNDA1, but MNDA1 can be positive in other small cell lymphomas. That's why morphology is important, and then we use immunohistochemistry as a helpful aid to confirm our suspicions or to mark the cells, to mark our cells of interest. Another way of using immunohistochemistry of daily basis, it's for classification. For example, on diffuse large B cell lymphomas, we use Heinz algorithm when we subclassify them as a germinal center B cell lymphomas or ABC subtype, which is an activated B cell type lymphomas. And for that reason, we use CD10 and BCL6 and MUM1, because germinal cell lymphomas will be CD10 positive. And if there is a CD10 negativity, then we have to proceed further to see if it's an activated B cell subtype, and there will be MUM1 positivity. There are cases when we can have a CD10 positivity, BCL6 and MUM1. In this case, it's a clue that we need to do a molecular study to see if there is an IRF4 molecular positive, fish is positive for IRF4. Another important markers in hematopathology, it's a Ki67. It's a proliferation fraction. And the low-grade lymphomas usually have low Ki67. The high-grade lymphomas will have a high Ki67, like 80, 90%, or even 100% if it's, for example, Burkitt lymphoma. Intermediate grade lymphoma, like diffuse large B-cell lymphoma, it will be 60%. So Ki67 is important marker. So another thing, it's when we use immunohistochemistry is a helpful tool to know if we need to proceed with molecular. For example, there is a double expressor lymphomas that express MYC and BCL2. MYC cutoff, we use 40%, and if there are 40% positivity in MYC, we call it positive. 70% positivity is positive for BCL2. And why it's important? Because double expressor lymphomas, they have a poor prognosis. They are worse compared to just a regular diffuse large B-cell lymphoma. And co-expression of these two proteins is more frequent in the ABC subtype lymphomas. Then if we have a double expressor by immunohistochemistry, then we usually proceed to do molecular, and we send a fish, we do a fish for MYC rearrangement to see if we have a MYC rearrangement in BCL2, BCL6, to confirm is it the only double expressor, or if it's also double hit lymphoma or triple hit lymphoma when we have MYC BCL2, MYC BCL2 and BCL6. Again, it's important for prognosis. So here we can see that it's a lymph node, but it's not a normal architecture of lymph node. The architecture here is effaced by diffuse proliferation. On a low power, it's hard to appreciate the cells are large, but you can definitely see that it's a diffuse proliferation of lymphoid cells. So, and when we do the markers, we immunophenotype using B cell lineage markers, CD20 and PAX5. And you can see that they both show that cells are positive and the cells are large, and it's a B cell lymphoma. Another important marker, as I mentioned, Ki67, to say there is a high proliferation rate here. And if we want to see if it's a double expressor or if there is lymphoma express MYC, then here we can see that this is a MYC positivity. This lymphoma is positive for MYC. But this is an example here. It's a spleen tissue, and you can see red pulp and white pulp. White pulp show lymphoid nodules. And in these lymphoid nodules, they enlarge with the expansion of marginal zone. And the next step would be to see if there is a lymphoma there, if there's increased amount of B cells. And again, we do the first line, we do CD20, PAX5 to confirm that they are B cells. If we are morphologically suspecting that it's not just a marginal zone expansion, but it's a marginal zone lymphoma, the helpful marker would be MNDA marker. And also doing Ki67 proliferation marker, it would be helpful to show us that it's a low-grade lymphoma because Ki67 is low compared to the previous picture where Ki67 was high. And usually low-grade lymphomas behave much better compared to the high-grade lymphomas that have a worse prognosis. Another everyday, another immunohistochemical stain that we use every day, it's a EBV, and we use two marker. One is a EBV LMP, which is immunostain, and another one is EBV in situ. And then nowadays recommended to do both because it's expression of them are different. For example, EBV in situ hybridization state is one of the most sensitive and widely available, and another one is a IHC EBV LMP. But for example, EBV LMP stain detect protein expression that is therefore more robust than EBER stain, and some LMP is not expressed, and the cells that will be positive for EBER by in situ. Plus, they also mark different cells. For example, if we have an NKT cell lymphoma nasal type, EBV will be present in the neoplastic cells, like T cell or NK cells. But if it's angioimmunoblastic T cell lymphoma, then EBV would be expressed in the B cells that are large and scattered. So you can see the different staining on the different cells. So when we are talking about oncogene tumor suppressor genes that we use and what immunostain we use in hematopathology, it's a BCL2, which is positive in follicular lymphoma. BCL6, as I mentioned, is a germinal center origin marker. ALK, we can have ALK positive B cell lymphomas. Cyclin D1 that is positive in mantle cell lymphomas and myelomas. P53 is very important because P53 show us a progression to a higher grade lymphomas, or P53 in a myeloid neoplasm show us that it is a myeloid neoplasm, and it's a worse prognosis. And again, if we have a MYC expression, then we have to proceed to do and look for MYC rearrangement. Another way how we can do immunophenotype in hematology is by using flow cytometry. So we can do immunophenotype by immunohistochemistry or flow cytometry. And flow cytometry method detects the presence or absent antigen on the white blood cells. Plus, it helps us to phenotype the same cells and see the pattern of antigen, and which is important for leukemias and lymphomas. Nowadays, we use, again, flow cytometry all the time. We use it for diagnosis, for classification, for staging, and for monitoring. For example, when we use it for minimal residual disease, and we use it for ALLs, and also now we use it for plasma cell neoplasm, like multiple myelomas. So what are the advantages of flow cytometry or using immunophenotype by flow cytometry compared to immunohistochemistry? It's rapid, it's hours, compared to when we use immunostains, it's days. Quantitative, we can use it on a limited amount of cells, but at the same time, we cannot see morphology. Like when we do immunohistochemistry, we see morphology, we evaluate cell morphologically, and then we phenotype it. By flow cytometry, we immunophenotype it, and then we use we look at the slides to see how the cell look morphologically. Then we use flow cytometry used to wash cells, and some cells may be destroyed during the washing process. And also on a flow cytometry, we use multiple fluorochrome, more than 4. And in our flow cytometry, we use 8-channel machine to do flow cytometry, but nowadays also there are availability of 12 channels machine. Flow cytometry is more difficult to send out because of availability, and we can lose availability. IHC, if we need to do some immunostains that we don't have in our institution, we can send it out. And since it's a paraffin fixed tissue, it's stable compared to the flow cytometry. When we are sending out the tissue, then we can lose the availability. one of the important markers that we use in flow cytometry, especially it's important for BALL, such as a B-cell acute lymphoblastic leukemia lymphoma, is the CRLF. CRLF plays important role in the development of normal B lymphocytes and in B lymphoblastic leukemia lymphoma, which is BCR-ABL-like, it's a provisional entity in the latest revision of WHO classification from 2017, and overexpression of CRLF is associated with particular poor clinical outcome. And now we have ability to do the CRLF marker by flow, and if it's positive, then it most likely will be positive for fish, and it gives a, first of all, we can classify it correctly, and second of all, it can give an opportunity for treatment and further follow-up and monitoring. So for CRLF, about the half of the cases that we have a CRLF by flow would also detect CRLF by fish. So you can see that immunophenotype can be done both by immunohistochemistry and by flow cytometry. And we have similar antibodies that we use in immunohistochemistry on a paraffin-fixed tissue, or that we use in a flow cytometry on a fresh tissue that was submitted in RPMI. And those two methods in hematopathology, they add to each other. So that's why we're not only using one method, we usually use both of them to fully characterize the process and then make a correct diagnosis, classify it properly, and also use important markers for treatment and prognosis. Thank you. I can stop sharing now.
Thank you so very much. And finally, we'll have Meredith James presenting, and then we'll open it up for questions.
All right, well, thank you again for taking the time to let me come in and talk to you guys today. So just a quick overview of Flagship. So Flagship's been around about 12 years, and we were founded by a pathologist who was very frustrated with the amount of data that we could actually get out of slides. And so we initially were using off-the-shelf software, very quickly realized that wasn't going to really be enough for what we were trying to do. So we actually spent 5 years developing in-house software to do image analysis and machine learning. So I'm going to talk to you a little bit today about what that looks like for targeted therapy development in cancer in particular. This can be applied to any tissue, but you know, since we're kind of in the space today talking about that, and obviously in immune oncology in particular is a very targeted space right now, and that's where this becomes pretty critical. So machine learning is just functionally a method where you're using computers to functionally learn as they look at various different data sets, identify patterns, and make decisions with minimal to no human interaction. That being said, at Flagship, we very much recognize the power of the pathologist as part of that process. And so what we're doing is what we call human in the loop. We're leveraging the power of that computer and those algorithms, but really including the human pathologist into that in order to make incredibly detailed, complex decisions that make sense in the context of the biology. So targeted drug therapy, again, if this may be high level, I was trying to target it to the audience without 100% knowing who was going to be here, is what we're seeing a lot in the immune oncology space right now. Precision medicines, where companies are developing drugs that are targeted to very, very specific markers compared to what we've seen in the past in regular oncology that are more broad spectrum. And that's where the need comes in to really understand not just that target, but maybe the tumor infiltration and the immune environment around that. As the complexity increases, so does the challenge from looking at these things in a manual way. So as a few of my colleagues talked about earlier, just talking about biomarkers and what those are, and that's basically anything within your biological system that are used to make diagnosis, look at basically trends in treatment and those sorts of things. Tissue biomarkers, obviously, is what we're going to be talking about a lot today in pathology due to the cancer immunology and the various different biomarkers and surrogates that we're trying to develop as we move through the drug development process. As far from an analysis workflow perspective, Flagship does have a CAP/CLIA wet lab, but we can bring in samples at any point in this process. And so what this enables you to do is to get a much higher level of consistency, particularly as you branch out in the development space and you are doing more and more larger trials, for example, you're looking at a phase 3 oncology trial, you may have 400 or 500 patients in almost every country in the world. And if you take a step back and think about what that might look like, if you're doing it in kind of the normal manual read way, you have 400 or 500 different pathologists potentially providing data that can be very subjective. And, you could potentially either enroll patients that are not appropriate or vice versa, potentially miss patients that could be key to your drug development space. So what we can do is bring in all those images internally, run machine algorithms and learning against that. Before it goes out from a report perspective, though, again, those pathologists have eyes on that data to make sure that it's making sense in the context of what we're looking at. So they're part of the process from the development perspective, but also prior to determining if the report can go out the door, whether the patient is positive or negative, should be treated, what that cutoff point looks like, et cetera. So just again, this is kind of a high overview of what machine learning, the workflow looks like. For our particular software, we can actually bring in as few as 5 to 10 tissues, sometimes even less, depending on what that indication looks like, and utilize those samples to train the machine and the algorithm to identify morphology. Within our software, we break everything down to a cell base, not a pixel base. So the system already understands that it's looking at a piece of tissue on a slide, and we're not breaking it down and then having to build it back up, which enables us to generate basically a SQL-like database of data per image. So depending again on what you're trying to find out from a biology perspective, you can look at things like nearest neighbor, various different interactions, how different molecules and markers interact with each other. Obviously, you can do this on a single stain, but what we're finding more and more is becoming more important or more requested is multiplexing. Currently, we're doing about 6 stains per slide in-house, and then obviously analysis, but we've also brought in images from MIBI and various other platforms where you're doing 30, 40 different endpoints per slide. And as you can imagine, having to be a human looking at a microscope at all of these different biomarkers, you're not going to be able to get the data that you really need. And that's where image analysis really comes into play as you're moving down further into this process. So this is an example of what you can do with the power of the software and turn these images into very complex data to help you answer the complicated questions that you can to generate within the context of a lot of these clinical trials. So for example, this is one of our standard IO panels. You've got some fairly standard markers, again, that pathologists will normally look at, maybe on a per slide basis, and we're going to layer them all over one slide and then provide a lot of information, not just about the individual biomarkers, but different things in context, which, as you can see, as my colleagues were alluding to earlier, if you have, different biomarkers and different expression levels, it'll really help you kind of narrow down what you're looking at. And then talking about nearest neighbor, what the tumor infiltrating lymphocytes look like, and those sorts of things, which are becoming more and more critical. And as we generate more data within the industry, understanding that lymphocytic environment is very critical to the response. It's not necessarily just is the tumor positive or negative, but what else is going on in that immune environment. So this is just a couple of examples of how the software can help provide solutions. We can do anything, obviously, from kind of early phase R&D to large clinical trials, and even lending that into clinical diagnostics. We've recently developed a first time KISH assay used for enrollment on a clinical trial, which I'm sure that my pathology colleagues on the call will acknowledge is very, very challenging and very time consuming to read. And that's where having some of these pathology assisted tools are critical to really be able to not just ensure that you're making the right diagnosis, but that you're consistent across the board as you're looking at a lot of these different markers in patients. For me, one of the biggest kind of most powerful things about image analysis and machine learning is that it reduces that variability that I talked about earlier. This was a study that we did in-house a number of years ago, where we had 3 different pathologists. There was a 2-week washout period, and we were really trying to look at what does that look like over time between different pathologists and then a pathologist with themselves over the course of this washout period, which is not uncommon, certainly in the tox space, but it also gives you some perspective on the clinical side as well. And what we found, the numbers are very powerful. And I think a lot of times this slide speaks for the complexity that we're facing today in the pathology world. if you're using digital, your margin of discrepancy and error is so low as to be negligible. But even pathologists with themselves over a 2-week washout period were only 64% concordant. And I think that's very telling in that, you have a pathologist that sits down, they look at a slide, they wait 2 weeks and look at the same slide. They won't necessarily give you the same answer because there's, thousands, if not hundreds of thousands of cells on that slide. And you're looking at various different intensity levels. Well, you're taking all of that out of the equation when you're allowing the machine to consistently say this is the intensity and this is the number of slides. So as long as you've done that kind of upfront machine learning process to ensure that the algorithm is consistent, you're really getting that very, very consistent data from slide to slide. As we move forward again and talk about kind of moving from trial to diagnostics, there's a lot of talk right now about having better consistency. This was a paper that was published a number of years ago, but I think it highlights some of the challenges that we have in immunopathology where maybe up to 20% of HER2, which is a fairly straightforward assay to read, may be inaccurate. You can validate, you can do a lot of things, but you're still at the end of the day 100% relying on a manual read from a person sitting in a microscope. So this is just also a couple of examples from CAP talking about how to interpret, I think this slide in particular just really shows the complexity of what pathologists have to deal with every day as they're sitting down and looking at various stains. You have to ensure that whoever ran the actual stain was consistent, did things the right way, and used the appropriate controls. Then you have to take into account that you have pathologists that are trained to read these and are able to catch maybe some of the subtleties. And they're even starting to recommend maybe using image analysis for interpretation because of a lot of these complexities to ensure that we can, anywhere possible, decrease that level of variability. Now, I think, the industry is still a little slow to pick some of these things up, but, it's been sitting around there for a while, and certainly the trend is increasing. But even from a research perspective, I think this is critical because it allows you to kind of start moving into that development phase with much more robust data. So recently, I don't know, again, how many of you are aware of this, we pulled some slides and we had some of our pathologists read them. We had some of the MU pathologists read them, and then we actually compared that to our image analysis solution. And I'll run through these slides pretty quick because I know we don't have a lot of time, but I also will have them available for you guys to review and send out. But I think, in general, it's pretty telling. So what we did, we used PDL1, which again is very complicated and fairly hard for pathologists to read if they're not doing it on a regular basis. And so we took people that from your group that we're not used to looking at these. Our team looks at them pretty regularly. And then of course you have the image analysis solution. So here you can see kind of what this correlation looks like. And I have some graphs in here, which obviously are a little easier to read than all the data, but it just gives you an idea of around the cut point, you're generally okay for PDL1 being kind of lower. And I think one of the things that frustrates me personally about PDL1 is that the cut point is so low and you're almost enrolling a lot of different people, but then you only see about a 23% response rate. So, what does that mean in the context of trying to provide diagnosis to patients? So my guess is that's going to shift over time. Even as we add additional indications, at some point, we're going to really have to start looking at, is 23% an acceptable number, or are we going to push the industry to really get much more robust data to ensure that we're capturing the right patients and maybe not giving patients drugs that shouldn't be getting them. They're expensive, and as we all know, they're not the safest to use in general. But you see, obviously, again, so the Missouri pathologist versus IA actually had a fairly tight correlation, again, around this bottom part where you would see the cut point. But as you start to get, kind of in that broader range of various different levels, you start to get a little bit more of a disparity, which again is not as unusual. And we've certainly seen this before. Obviously, again, our pathologists who are used to looking at these image analysis solutions a little tighter, but ultimately, and again, this is rank ordered by low to high scores. So as you see where it's a little more obvious, it's a little easier to read. And when it's closer to 0, it's easier to read. And then you get in this middle range. And that's where a lot of this complexity comes in. But again, at the end of the day, that this is a small sample subset, but what we see consistently, even, our own internal pathologists struggle with, as you get into these more complex assays, things like multiplexing or KISH or various other things that we're starting to get requests for in order to generate that level of data, it's nearly impossible for them manually to provide the level of data that most clients want to see. So I know I kind of ran through this really fast, and I don't want to cut into question time too much. So I will stop there, but I will say in the deck, I also included an appendix that kind of gives you an overview of interpretation guidelines and a kind of a more detailed breakdown of how the image analysis works.
Thank you, Meredith. I am so impressed with 3 speakers that everyone stayed on time. That's really cool. I would like to invite everyone. I know we've posted in the chat that you can submit questions there, but if you wanted to just, we're a small group. If you wanted to turn your camera on or just your sound on, and if you have any questions for the group, please do share.
One thing I'd like to just say just to the group is we often here at Pathology, I'm sure Meredith does as well, work with researchers in the basic sciences. And obviously, this is what we do every day. We're pretty much live and die by our immunohistochemistries and interpretations of them. And we're here as a resource to help you with your research projects. And that will also help you in the long run. I would suggest, though, that you consult us at the beginning of your project rather than at the end. Very commonly, we have people who see us after they've spent 6 months doing something and then figure out they did everything wrong. So it would save you a lot of time, effort, and likely money just to ask us questions that we would probably think as are very simple for us, but also understanding it's sort of a niche area that not everyone's real familiar with.
That's a great point, Rich. And we've had clients come in who have worked with either internal resources or various other external resources. And after about a year of spending, obviously, what turns out to be a lot of money and frustration, come to us, and being able to break that down in a more scientific way to try to understand the problem instead of just doing what they ask, I think is really critical here, particularly as we move farther into these very complicated assays and biomarkers and sorts of those things.
So it's been my experience. I've seen just even today, actually, somebody showed me some slides after a year-long project. And if they would have just asked me at the front, it would have been so better and easier. And now we're trying to recover a year's worth of work and basically save it rather than when just a little pre-planning and discussion on the front end could have made things a lot better.
Okay, well, I think that's a lot of great information, and I really appreciate that advice at the end. We're going to share this link with the group, the EFCC distribution list, and so they can have the chance to see this recording. Thank you, everyone, for being here.
Thank you.
Thank you.